This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh, your co-host, and the aforementioned Dr. Brian Schmutzler. Brian, thanks so much for having me on the podcast. I know we kind of want to do an question-answer format. So I'm going to be serving as the patient.
Nice.
And, of course, you're the doctor.
Of course I am.
Give us a little background of you, where you studied and what you're doing now.
Yeah, sure, absolutely. So I grew up right outside of Indianapolis. I went to college at Notre Dame, near where I live now. After college, went to medical school at Indiana University School of Medicine. I did a combined MD, PhD program, so I did a couple years of medical school, went and did my PhD research, came back and finished medical school, did a little acupuncture training in Tempe, Arizona, and then did my residency also at IU down in Indianapolis. And then after that, I've been up here in northern Indiana ever since, practicing anesthesia and trying to be a good human being.
You are a good human being. I can attest to that. And, of course, you have been very, very active on social media, answering people's questions and mixing in a little fun besides I know you're kind of new to the social media world. How do you like it?
Yeah, it's fun. It's fun. I'm not naturally a type of guy who likes to be on camera, who likes to talk in front of a lot of people. In front of a camera anyway, but it's been fun. I've gotten a little bit more used to that. I feel like our videos have gotten more and more fun and natural, so kind of a next step. Let's just chat about these questions. I feel like sometimes on social media I don't have enough time or enough ability to answer the questions in the detail I'd like to. So hopefully this gives people a chance to get their questions answered in the detail that they deserve.
Well, hundreds and hundreds of questions have been coming in through social media, like you said, so we're going to do our best to answer these throughout Season 1 here. Again, this is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. All right, every week we're going to do like a main topic that, Brian, you're going to talk about and highlight a little more in depth than a normal Q&A. Maybe spend 5 minutes or so on this topic, 5 to 10 minutes. So what is today's main topic?
Well, it's Heart Health Month, Heart Month, the month of February. Obviously, they kind of mix that with Valentine's Day. And so a lot of you who have seen my social media posts saw that I had a carotid scan. And so I'd like to talk a little bit about what that is, what that means, and then talk about overall heart health, what I do to stay healthy, and sort of the tests that I do and the way that I maintain my heart health. So the test I had was a carotid ultrasound. So that scanned my carotid arteries to see if I had any plaques. Carotid artery plaques and carotid artery stenosis are the leading cause of stroke in the United States. And so...
Wait, so let me pause you there. How
Sure.
do you even, know to take that scan? Like, I'm an average dude.
Yeah.
I'm not a physician. But how do I know even to I got to look here, or who told you about that? Or how did you know about that?
So a couple of things. I have a primary care physician who's a functional medicine specialist. Her name's Dr. Lisa Miller in Indianapolis. She recommended it to me. And I've also spent a lot of time reading and listening to and following Peter Attia, who's a general surgeon in Austin, Texas, who also recommends a lot of things for this. So I think getting in with a really good primary care doctor who's looking not only at what the guidelines are specifically, but looking at sort of these more functional medicine type topics, these type of things where we're doing preventative medicine 10, 20, 30 years out, not just risk in the next 5 years.
So what did they find? I mean, you go in for the exam.
Yep.
What did they find? And, what was your reaction, I guess?
Yeah, so they scanned the carotid arteries. I have no plaques, which is great. It means my risk for a stroke is very, very low. They also do what's called a CIMT, complicated, but basically what they're doing is measuring how thick the arteries are. The thicker your arteries are, the more likely you are to form a plaque and then to have issues with your carotid arteries. And so my intimal thickening was very, very minimal. It gives you a kind of a score of how old you are in terms of your vasculature, and my carotid artery showed that my age was 32, which is about a decade younger than I actually am. So I was very, very happy with that.
You're lucky, man. You're lucky.
Yeah. I've got family history of coronary disease, of cardiac disease. My family history is a little bit skewed because almost everybody in my family smoked. Smoking is the number one preventable risk factor for cardiac disease, vascular disease, and respiratory disease. So For me, I'm trying to do a lot of things just to figure out where I am baseline, because I just don't know, because my family history is hard to tell. So,
all right. So if you were to recommend this to an average person, we know about like the calcium. Like I just got a heart test, right?
Yep.
The calcium test.
Yep.
But the carotid test, like, or other tests that we don't know about, unless we're told,
right?
How do we go about doing that?
Well, I mean, number one, follow me. But
obviously,
obviously. Aside from that, I mean, just do your research. There are a lot of people out there. Myself, like I said, Peter Attia. There's a lot of really great primary care docs and functional medicine docs who are looking at this sort of stuff. I actually, and you mentioned, you had a heart scan. I'm actually having a heart scan at the end of the month, and so I'm doing a whole battery of tests that Dr. Miller recommended. And I have a VO2 max measured, and this is a big thing that Peter Attia talks about as well. But your VO2 max is really the maximum oxygen utilization that your body can do, and so as we get older, that tends to drop. But if you can keep it up, you're going to have longer. What he says, basically healthy years, where you can get around, you can go upstairs, you can take care of yourself at home. I'm getting a DEXA scan done, which will tell sort of my bone mass, which is not something I'm worried about as a 40-year-old male, but also body water, body mass, muscles, amount of muscle. So it does a really nice comprehensive measure of that.
What can that do? Like in terms of, I mean, can it see if you have bone cancer? I mean, like what are the preventative measures if you're 40 years old and not 70?
Yeah, it tells you how strong your bones are. So if for some reason there was something in there that said, hey, your bones aren't as strong as you think, adding some calcium is something you can do. But telling your muscle mass and your overall fat in your body can help you push yourself towards doing something to correct that, right? More muscle, less fat. Always a good thing, no matter how old you are. And then I'm having the heart scan done. And maybe let's just talk a minute about what a heart scan is. Essentially, it's an X-ray or a CT scan of your heart that shows how much calcium you have in the vasculature in your heart, in your coronary arteries. And so I don't remember the exact scoring system, but a low score means you're low risk for the next 5 to 10 years to have any sort of cardiac event. A high score means you're high risk. And so again, given my sort of unknown family history, I really want to get a sense where I am baseline. Now I'm 42. I'm in pretty good health. I'm a little bit heavier than I probably should be, but who isn't? And so I just want to see kind of where my baseline is on that.
So I had a test done a few days ago, and it wasn't full on terrible, right? It wasn't a terrible score. He didn't really give me my score. I'm 43 years old, so I mean, like, heart disease runs in my family, and never really had a checkup before in terms of a heart checkup. Otherwise, pretty healthy, I would say, and it was a really easy test. So if you're out there and you're like, hey, I don't want to get poked and prodded or whatever, it's really nothing. I mean, it's a 5-minute test. You go in, they put the
EKG pads on your heart.
Yep, and there's like 3 of them.
Yep.
They take you in this tube, and it's not really that claustrophobic. They're scanning pictures for 5 minutes, maybe less, and you're out, and you're done. He took me around, and he's like, hey, you have a couple calcium spots to be aware of. They're not that big of a deal, but, hey, maybe we're going to put you on some beta blockers or some other preventative measures to help you kind of, regulate the calcium in your body.
Yep. So not so much the regulation of the calcium. So the way that it works is the cholesterol in your body ends up depositing on your coronary arteries. And when the cholesterol deposits, then your body kind of walls that off with calcium. So it's not that you have a calcium issue. The big issue is cholesterol. And so the big thing with that is there's different types of cholesterol, and we can get way deep in the weeds with this, but there's good cholesterol HDL and there's bad cholesterol LDL, and then there's also triglycerides, which are kind of precursors to fat and come and build into fats. And so you want your HDL to be high and your LDL to be low, but it's even more complex than that because there are specific types of LDLs and types of apoproteins that make you higher risk for things like coronary disease, for things like even dementia. They increase your risk for that. And so the push, and this is something I've really gotten into recently, the push now is to get your LDL cholesterol very, very low. I mean, as low as you possibly can. There's a lot of people, Peter Attia being one, who argues that your LDL cholesterol should be 30 or less. The guidelines when I was in medical school 20 years ago was 160 or less. And over time, even kind of standard medicine has said, well, then 130 and then 110, and now it's under 100 is the standard for your cholesterol. So that's a big thing, modifiable risk factor. As I said, smoking, huge modifiable risk factor. And then blood pressure. You want to keep your blood pressure under 120/80. And some people would even argue under 110/70.
So what's the other factors, right? I mean, like, I don't smoke. Blood pressure is pretty good. Working out. Yep. What the foods you eat, right? I mean, like eggs, right? I mean, are eggs good or are they bad cholesterol? That is one question I wanted to ask you.
So this is a debate in the literature. I'm not a diabetologist. I'm not a nutritionist. I don't, I'm not a specialist in cholesterol. So I can't answer that question fully. What I would tell you, though, is that cholesterol doesn't raise your cholesterol. So foods that are high in cholesterol don't actually raise your cholesterol, right? It's usually processed foods and high carbohydrate foods. Those create your triglycerides. Those triglycerides then create the fats, and that increases your LDL cholesterol. So, I mean, modifiable risk factors, like we said, the three, but also weight, right? So taking in less calories than you're burning and keeping yourself in a little bit of calorie deficit is going to help a ton in terms of weight loss and keeping weight off. So keeping your BMI, most people would recommend under 25. BMI is not a perfect measure because if you're a big, strong, muscular guy, your BMI might be higher than 25.
Obese, right?
Right, yeah, you could be obese and still be very low fat, very high muscle. So that, and then, exercise and diet, the two things that you can do yourself without any medications. Exercising, they say somewhere between 30 and 60 minutes a day, 5 to 6 days a week, and then trying to eat as clean as possible, staying away from processed foods, staying away from high fat, high calorie, high carbohydrate foods, processed carbohydrates in particular.
Well, my trainer this morning is not going to be happy that I did not go. Hey, that is part of it, right?
That is, yeah. And doing different kinds of training, too, not just cardiovascular training. Yeah, not just aerobic training, but anaerobic training, building up muscle. That's big as well.
All right, let's get to some of our questions today. Again, this is Going Under Anesthesia Answered with Dr. Brian Schmutzler, who's been in the anesthesia game for
about a decade.
Yeah, more than two decades, right?
Well, medical school, but actually doing anesthesia about a decade, yeah.
All right, so our first question here, and these are all from Brian's social media page, so we're taking these questions directly from there, so hopefully we'll get to your question within the next year or so, if we can do that. The first question, Brian, is it the propofol or inhaled volatile gas that causes lungs to feel irritated and you feel wiped out for a week or two post-op?
Yeah, so those are two separate questions. What makes your lungs feel irritated? That's going to be the volatile anesthetics. Propofol is an IV medication, doesn't go anywhere near your lungs. The volatile anesthetics go through the endotracheal tube or the LMA. Those are what would cause your lungs to feel weird, particularly if you have reactive airway disease like asthma or COPD. That'll make your lungs hurt or not feel great. Sometimes, not with everybody. What makes you feel wiped out for a week or so? Doesn't always happen, but there's a lot of factors to that. So surgery itself is tough on your body. That can make you feel wiped out for a week or so. Certainly the volatile anesthetics or the propofol can hang around for a little while, particularly in older people. They don't process it quite as quickly. So that can hang around for quite a while. And then both of those medications end up being fat soluble and get stored in your fat. More so the volatile anesthetics than propofol, but those can hang around for several days as well.
Okay, and question number 2. What should I do if I want to have breast surgery, but I suffer from malignant hypothermia? Is it even possible?
Yeah, it's 100% possible, and I've done cases like this, several of them. Malignant hyperthermia, just for a little background, typically a genetic disorder where patients are reactive to some of our anesthetics. So the volatile anesthetics, as well as succinylcholine, which is a medication we use to paralyze or to stop the muscles from moving. So what happens in a malignant hyperthermia crisis is you give these medications and the body releases a ton of calcium, which locks up the muscles, causes kidney damage. There's a whole array of things that happen. So it's potentially fatal, 30 to 50% fatality rate. And so, usually it runs in families because it is genetic. And so we usually know that ahead of time. You had, your grandmother and your mom and your cousin and all these people had problems with anesthesia. So we do a two-step approach with breast procedures. We'll do a numbing block. The numbing block I like to use is an erector spinae plane block. Usually put a catheter that stays in for a few days as well in that block. So that helps with the pain relief. And then we do what's called a TIVA, or total IV anesthesia. So we can avoid the volatile anesthetics completely, and we can avoid succinylcholine completely. So we use all medicines that don't trigger that crisis. Typically for me, what I'll use some propofol. I'll use some either remifentanil or sufentanil, which are sedatives but also pain medications. And then we'll use a paralytic that's non-triggering, such as rocuronium, and then we'll reverse that rocuronium with a medication called Sugamidex. And overall, people have done great with that.
All right, another question here. Just had GA, which stands for?
General anesthesia.
And came out orthostatic, which means?
Orthostatic means that your blood pressure drops when you sit up, and then it raises back up when you lay down.
Got some big words I need to study.
I know.
Had to stay overnight. Is this a side effect from the anesthesia?
It certainly could be a side effect from anesthesia. Anesthesia in general causes your blood pressure to drop. So if you've got sort of borderline orthostatic hypotension anyway, which a lot of people over the age of 60, 65 do, and then you put the anesthetic on top of it, that'll kick you into kind of full-on orthostatic hypotension. Again, as the anesthetic wears off, usually you head home and never really have any further effects from it, but not totally uncommon. And, people talk a lot about, I had to stay in the hospital. What I usually tell patients is as long as you're safe and your vital signs are stable, if you have to stay, you have to stay. If you have to stay in my PACU for 4, 5, 6 hours, it is what it is. I'm okay with that as long as you're safe.
Not the worst thing in the world if you're being looked at. If you're being looked after, right?
Definitely.
All right, next question here. How does one go about lowering or keeping their vascular health age low? We kind of talked about this, like jogging or other exercise or other cardio.
Yeah, so aerobic exercises, in general, static or stable aerobic exercises like running at 6 or 7 miles an hour for half an hour, that's good for your cardiovascular health, but it doesn't seem to be as good as high-intensity interval training or what I'm really working on myself now is VO2 max training. So doing intervals that get my heart rate up in that 80 to 85%, maybe even 90% heart rate range for 4 minutes, which is terribly difficult. I mean, I'm in pretty good shape. I'm not the best in shape in the world, but I'm in pretty good shape. And VO2 max training is brutal. So that really helps your cardiovascular health to stay young, as they said in the question, and then keeping cholesterol low. And then if you need it, take the medications. That'll keep your cholesterol low, blood pressure low, so that you can overcome the family history usually that people have.
I did VO2 max training back when running marathons, and hey, listen, your oxygen intake is the best it's ever been, but it's brutal and it's tough.
It is painful. And it's more than just the interval training, which is a minute here,
right,
a minute there, a minute here, a minute there. High-low intervals. You get to 2.5, 3 minutes at 85, 90% max heart rate, and you are huffing and puffing. I mean, I can barely move my legs at that point. So,
but he's in shape. Is it typical for anesthesia to increase blood pressure? Just wondering about if a patient has increased blood pressure through the entire procedure.
So as I mentioned before, usually anesthesia causes low blood pressure or hypotension. Occasionally, there are some medications that can increase the blood pressure. And, honestly, more often when I see high blood pressure or hypertension during a procedure, it means that the patient either isn't anesthetized enough or hasn't gotten enough pain medication or regional anesthesia. And so, I don't see a lot of high blood pressure in the operating room. I probably see 95 to 99% low blood pressure and 1 to 5% high blood pressure. So it's pretty rare in the operating room.
All right, the last question is, again, these are all from your social media pages, so we appreciate the questions coming through, and we're going to grab them here as the season, as we go through season number 1. Our final question today is, can we use dexamethasone as antiemetic?
Yeah, so let me just go through and kind of explain we go back.
Please
to the
do, because I feel like I'm reading it. I'm going through the dictionary right now, spitting these words up.
So dexamethasone is an IV intravenous steroid. Pretty high potency, not as high potency as something like hydrocortisone, which is another IV. You may have heard of that for putting on your skin for say rashes or itching or something. But dexamethasone, fairly potent IV steroid. For some reason, it works in going to the center of the brain that causes nausea and vomiting. And helps prevent nausea and vomiting. So I personally use 10 milligrams IV dexamethasone on essentially every patient who doesn't have a contraindication to it. So antiemetic means anti-nausea for those of you who may need a little bit of medical dictionary help here. And so what we typically do, and this is one of the big standard quality measures in anesthesia, we use at least 2 different classes of medications that reduce nausea, post-op nausea and vomiting. I almost always use Zofran or ondansetron. That one works by hitting serotonin receptors. And then I also use dexamethasone, which is the steroid-based medication. Those 2 together prevent nausea in the majority of people. We have several other classes of drugs that we can use. But I guess in answer to that question, yes, dexamethasone is, I would say, standard of care for anti-nausea, anti-post-op nausea and vomiting in all except brittle diabetics, because steroids can cause your blood glucose, the amount of sugar in your blood to go up.
These are all very, very good questions, and we appreciate you sending them in. And if you have questions, either you can put them below in the chat, or you can send them to Dr. Brian Schmutzler. Just go find his website. It's drbrianschmutzler.com.
Yeah.
So,
and at Dr. Brian Schmutzler on Instagram, search Dr. Brian Schmutzler on Facebook, and we're on TikTok as well. So
he is all over the social media channels. Again, if you have a question, put it down in the chat below. Brian, anything else you want to add here as we wrap up our first episode?
No, I thought it's been fun. Been a good time. You're a great host. Love to continue to do this for as many episodes as we can get out there, and as long as we keep having questions, I'm going to keep answering them. Keep picking topics. I think this month being Heart Month, it's a great first topic, talking about heart health and vascular health, and we'll keep bringing the info to our fans out there.
Awesome. Thanks so much, Brian. And this has been Going Under, Anesthesia Answered with Dr. Brian Schmutzler. Again, you can follow him on Facebook, Instagram, and TikTok, and YouTube as well now. Or go to his website, www.drbrianschmutzler.com. We'll see you in the next episode.